Okay, so after you've done what you need to do to get the teeth ready, the doctor will come in, they're gonna sit down, they're gonna make sure they like everything, and then we're gonna go ahead with the composite teeth or tooth. So they will place a layer of flowable. Some doctors will do this, some won't. It just depends on where you are. But they're just gonna place a thin layer of flowable if they do. And this helps to give us a little bit more of a mechanical lock between our flowable and our packable composite.
Secure that.
Oh yeah. So, and then some offices will cure, some won't. It's going to depend on your doctor. I like these new ones.
Mm-hmm.
They're fancy. We have new curing lights, by the way. Okay. And so then the doctor is going to start with the packable. And this is going to be a little bit of back and forth because remember, composite is placed in 2 millimeter increments. Okay. All right. And so typically we'll give them some type of instrument. This is a Ladmore burnisher. And notice that.
Oh, no, wait, you said bond. Sorry.
Yeah. So sometimes the doctor will want to dip the instrument in the bond. They'll have you wipe off possibly and you stay close so that if they have to come out to dip again to keep the material from sticking to the instrument, we are good to go. Okay? When they place it firmly, you know they're done. You'll always hand them something to keep their hands busy while you light cure. Otherwise, they start playing with your instruments. Oh, that's super fancy. Okay, and so this back and forth will continue. There we go. Okay. And remember what you learned in dental material, or materials, not material. When we place composite and we light cure it, we get polymerization shrinkage. And so that will pull, the material will pull in towards the middle of itself. And so we don't want to have any micro leakage or microscopic gaps that will cause micro leakage. Get out of there. So we will, or the doctor will overfill that restoration. Okay? So this is why it's going to be a couple of times back and forth because we're only doing those 2 millimeter increments and then they are going to overfill just a little bit. Weird that you have to set it every time though.
I keep pushing the button.
Oh, okay.
If I just push start, it would be okay.
Oh, okay. Getting used to new things is fun.
Yeah.
Okay, and so we're going to put just a little bit more to make sure that we are compensating for that polymerization shrinkage. And why am I saying all these words to you? Because you're going to see them on your national board whenever you take GC in the summer. Or you're going to get that doctor that quizzes you, and I want you to be prepared. Because we have a few that will do that now. They don't just let you sit and stare. I'm going to make a side note and say that I am not a dentist. So this is not going to be perfect. But it's okay. He hadn't complained yet. All right. All right. And so typically for the last time that we light cure, the doctor will probably take the curing light and allow you to get whatever you need ready for the next restoration, which is going to be our amalgam. So right now Miss Hubbard is getting the bond ready. She is adding bond B to bond A. And then she's going to place it in the tooth that we're doing the amalgam on. Okay. And remember, like she said before, you want to make sure you get it in every space inside that prep. Gentle burst of air. And then we are ready to go ahead. Fell out on me. It did. And you burnished it too. I saw you.
Okay, I'm going to hand the smaller end to the dentist first because they're going to put that into the interproximal box.
So we're going to start where that wall was missing, and they'll place it there first, and then they will rotate around and hopefully get the other one out. Now it doesn't want to come out. Now it went back there. This is just fun. All right. Okay. And so now she's handed me, first she handed me the amalgam carrier, and now she's given me a condenser to condense the material into the prep. Okay. And so then she's going to transfer. And the doctor can hear that you're mixing another one. So they're going to be okay. You don't have to say anything to them, because you can see if there was enough amalgam or not in the prep while you're working. Okay? And this is why we position ourselves a little bit above the working area, to make sure that we can see what's going on. Okay?
Give you this end.
Thank you. That might be good.
Okay.
Actually. Okay, and so notice I'm not having to tell her I want this instrument next or I want this next. She's gonna know like what we're gonna need. And so with that, while we're condensing, we would make sure that we, yep, there we go. Just keep going. Okay, and they don't want to be waiting on you. Sometimes you're going to have to wait on them. All right, but we've given them a burnisher, and then we're going to go back and we can do occlusal carving right now, so we can get some anatomy. And again, I'm not a dentist, so this is not going to be pretty. Note that Ms. Hubbard has grabbed her suction, because you can see we're pulling off little bits of amalgam, and so she's suctioning it up to keep the area clean. And then sometimes when you're working with a Toffelmeyer retainer or any type of matrix, when the doctor is finished they might want an explorer to go and clean around the band. Go ahead.
I don't have it on right now, but your HPE should be on at all times while they're carving or taking away amalgam.
Okay. And so when they're done, that is going to be the time we would go in and do a final suction, and then we're going to remove the matrix band. Okay. Which, if you just want to. Okay. And so if the doctor stays in to do this, you're just going to take, we're undoing that outer knob, we're keeping a finger over, okay, and you'll be the one to just hand them things or take things from them. And remember, this is just a gentle teasing of the band, one side and then the other, and then you'll carefully take that, and then we're going to do any of our interproximal carving that we need. Okay. And then please notice how she's handing me that floss. This allows the doctor to come in, wrap it around their middle fingers, okay? And then what they're gonna do is they're gonna floss in the contacts, okay? And can I see CR20? Let me see if I can get that real quick. Sometimes we get things where we don't want them, and so this is why we always check before we send the patients home, and they can't floss. Let's see if they got it. It's right there. All right.
You notice I didn't put it away until I'm sure that she is done with it.
Mm-hmm.
We'll just keep going back and forth until she says she's done.
Yeah. And so sometimes your doctors will come from different angles. Again, I am not a doctor, which is why this also happened. And that's okay. All right, let's see if that got it. Yay. Haha. And then your doctor will celebrate and throw it away. So the other thing that we would do, the doctor might go back and smooth it up a little bit more. They might do it with polishing at the end, but we also wanted to one more time show you placement of an IRM. So we're going to do that real quick, and then we'll go through the final steps of the procedure.
Just mix it over here and then I'll get into the operating chair to place it. Okay.
She's starting to strop or push that material into the pad.
to use my Lattimore. I'm going to put it on the end of my Lattimore, like this, the best we can. Then I'm going to place it, oh, let's do the big one here. Place it over the hole I need to. I'm going to put my thumb there, pull out my Lattimore, and then I'm going to use my thumb to push in there really hard and wipe it as I'm pushing. That takes off almost all of the excess, okay? Then all I have to do is go in there and finish it up. We notice that it's straight across. We don't want that. We want it to be cup shaped a little bit. So I take, and this is just my personal thing, I take the back of the Lattimore. Can you see it? And I go in and I just do like a little scoop, like that, sorry. Okay, and that's what I do. Do it again.
Mm-hmm.
Okay, so I take the back of my Lattimore, I go in there and I just kind of scoop it out. Okay. Then I make sure that it's all burnished around the edges. Okay. All right. Then you can take a cotton roll or a cotton swab or cotton tip applicator that's wet. And if you'll just run it along and clean off all the excess, the water in the cotton tip will smooth it out, take off some of the excess, and it'll also speed up the set of the IRM. Okay. Now I know that I have some in approximately, so I'm going to make sure that I get that out with my floss. So with my floss, I'm going to take it and I'm going to tie a knot in it so that it can grab a hold of the IRM and pull it out of there, okay? Just towards the end. Then when I floss, I'll pop it through the contact, do my knot through there a couple of times, and then pull it through. Let's do the back side too. Okay. You see my cotton tip? There it is. I just want to go back one more time and smooth it out just a little bit more. Happy little clouds. Are you comparing me to him?
You're an artist, yes.
An artist. Thought you were talking about my voice.
No.
Okay. All right. Once that's done, let's take off the rubber dam here. I'm gonna come in. Take off the. That's why we wear glasses. Okay. I'm gonna pull it off at the same time. So I'm gonna grab the wedge it here, and try to get all this off at the same time. Okay. And since I didn't cut the septum before, like you're supposed to do, I need to look and make sure that none of it's still on the inside. Okay. The easier way to get that off is to pull it out while it's on the teeth, cut the septum, and then take it off. All good. Now I want to give the patient a nice good rinse. I'll go around to the other side so the doctor can sit down. That kind of hurt. The vestibule. Okay, and then clear it from their throat by sticking it in the corners on the sides, not down the back of their throat.
Okay. And so then the doctor would come back in because they knew you were doing that, and we're just going to do one final check for the patient with their bite. And so the doctor would hand the articulating paper, and we would have the patient actually bite down The doctor would say, tap, 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 slide your teeth all about. And what you should see is the marking of whatever color, so we had red, on the cusps and not on the restorative material itself, which I'm not seeing any on the restorative material. So we have done a good job today. If for any reason there was red on the restoration, then it would be the back and forth of, I need to hand some instruments, maybe we do a discoid cleoid again. If it was the amalgam, we would do a burnisher to smooth it back up. If it was on the composite, we would do the hand piece and we would have that back and forth exchange. But regardless of what we have to do, you're still going to go back and clean up the patient's mouth at the end so that they don't walk out looking like they've had some type of strawberry or blueberry, depending on the color. And so all you would do is just take either a 2x2 or a cotton roll and run it along those teeth to get that marking off for them, and then give them their post-op instructions. And when you give post-op instructions, it needs to be the same thing for the same procedures all the time. Don't leave it open-ended, okay? So for this patient, we would tell them, don't eat anything until the numbness wears off, because you're still going to be numb for a little bit. We don't want you to bite your cheek or your lips or your tongue because you're not going to have sensation and you might bite through them and need stitches. So if you're hungry now, please get like some soup or a milkshake to tide you over until that sensation comes back. We also don't want the patient to eat anything hard or crunchy on this side because they have an amalgam restoration. And that amalgam's not going to be fully set for 24 hours. So we don't want them to break it and have to come back in and us do a larger restoration. With the temporary, we want to make sure that we explain to them that we've put that temporary in place because maybe the doctor started prepping and they realized, oh, this is a bigger restoration than what we had planned for, and it's going to need a root canal or something different. They would have already had that conversation with the patient, but what we need to make sure they understand is that's not meant to be there forever. It is designed to get them by until we can get them back in for that scheduled appointment. If it was a patient who was in pain, that pain is probably going to be relieved because the IRM has that clove oil component to it, so it's soothing to the tissue. So we have to make them understand this isn't designed to last. I've had patients before who have tried to make them last 6 months to a year, and then they come back in, they've fallen out, and they've actually broken off bits of the tooth around it. So it ends up being an even more complex case. So again, stress that we need to get them back in and set that appointment, or get the front to set that appointment. They should have some sensitivity because we have been cutting into teeth. So the cold sensitivity should go away in about a week or so. If it gets worse, if it is bothering them, they can call the office and we'll talk to them and see if we need them to come back in. If they have any heat sensitivity though, they do need to call the office because that can be indicative of a bigger problem that may lead to a root canal. Okay? And then beyond that, we would make sure that we give them their next appointment, and we would write up our chart and dismiss them. And that's it. Hooray.